Okay, so everyone over there as well. Would somebody mind hitting got it over on the other computer? Thank you. Okay, great. So for people who are watching this on recording, you might not be able to see the whiteboard very well. I apologize, but everything that I write on the whiteboard will also be on a slide, so you should be able to still see everything. But you are the intern on VA wards, and you just got here this morning. You got sign out from the overnight teams, heard about your night admissions, and you're sitting down to review people, and then you get a page. And it's a patient's nurse, and she says, hey, Mr. Jones just doesn't look good. He says he's nauseous and he's more sleepy. And you look down at your sign out, and Mr. Jones is a guy who came in last night. He was having some pre-syncope, recurrent falls, and dark stools. And you ask for the patient's vitals. The patient's nurse says his temperature is 36.1, his heart rate is 125. It was 95 the last time I checked it. Thanks, Julia. His blood pressure is 105/80, down from 115/85. His respiratory rate is 24, and his O2 set is 92% on room air. So then you think to yourself, is this patient in shock? Do I need to be worried about this patient? If he is in shock, how do you know? And why? So today we will define shock, list 4 main categories of shock. We'll also build a physical exam-based algorithmic approach to the patient with undifferentiated shock, and then apply this algorithm to clinical cases. The main goal of today is to be able to rapidly assess a patient with shock and figure out why you think they have shock. It's not necessarily a management-based lecture, just because management of each different kind of shock is sort of its own talk in and of itself, but I'm happy to answer management questions if you guys have any. So think to yourself for a second, what is shock? I feel like as a medical student and as an early intern, I equated shock with hypotension, but is that true? Are those the same thing? And so the definition of shock is inadequate perfusion or inadequate oxygen supply to meet the body's demands. Notice that that definition does not include hypotension. Patients with shock often are hypotensive, but not always. And not all hypotensive patients are in shock. You think about your patient with chronic liver disease and chronic hypotension because of that. Patient's not necessarily in shock. So, yeah.
I think in shock, they have to have like and organ damage.
Yes, exactly. So if we can't rely on blood pressure alone, then what do we rely on? We rely on clinical evidence of lack of end organ perfusion and also laboratory evidence. So think about if you don't have enough cerebral perfusion, might manifest as encephalopathy, confusion, lethargy. If you don't have enough renal perfusion, might manifest as decreased urine output, or maybe an elevated BUN and creatinine. Or maybe on labs, you see an elevated lactate from anaerobic metabolism, from tissue in general not getting enough blood supply, not getting enough oxygen. Great. So we have 4 main categories of shock. Can anybody name one? Hypovolemic, great, which includes hemorrhagic or shock from blood loss. Can't spell.
Cardiogenic.
Great. Great. Distributed and obstructive.
I have a question.
Yeah.
You need to click the joint audio, record your voice.
I am recording from my laptop and have audio on here, but thank you. Thank you for pointing that out. Okay, great. So we said hypovolemic includes hemorrhagic or general volume depletion. What are some causes or types of cardiogenic shock? MI, great, I heard MI. So acute MI, or maybe chronic heart failure that's acutely decompensated.
Tamponade.
Tamponade, great, is a type of obstructive shock. What are some other types or causes of obstructive shock? PE. PE, great, a massive PE. One other big one. Great, tension pneumothorax. And then causes of distributive shock. Septic, great, the biggest one.
Neurogenic.
Great, neurogenic shock. Yeah, adrenal insufficiency, you could lump under distributive or maybe its own category, but I agree. And then the other one is acute liver failure, generalized vasodilation from acute liver failure. Great. And so we said that not all patients with shock are hypotensive, but many are. And so organ perfusion is mostly determined by mean arterial pressure. Again, you can't have a normal map and also be in shock. But if we think a little bit about these types of shock in terms of mean arterial pressure is determined by two things. What are they? Great, systolic and diastolic blood pressure, yes. That is how you calculate a mean arterial pressure. There are two main parameters or like physiologic principles that determine mean arterial pressure. Great. Cardiac output and systemic vascular resistance. So think about it this way. Hypovolemic shock. What's the main problem? Cardiac output or SVR?
No, sorry.
Cardiac output, right. So cardiac output is decreased because cardiac output additionally is a function of stroke volume times heart rate. So if you don't have enough volume, you don't have enough stroke volume, cardiac output goes down. And then how do we compensate for that? Increase SVR, great. So blood vessels will clamp down to try to maintain mean arterial pressure. How about cardiogenic shock? Problem cardiac output or problem systemic vascular resistance? Great, problem is cardiac output. Mostly a stroke volume problem, usually from lack of inotropy. And similarly, we compensate by an increase in systemic vascular resistance. How about distributive shock?
SVR.
Great, SVR decreases from systemic vasodilation. So what happens to cardiac output? Increases. And then last category, obstructive shock. What's the problem? Cardiac output, great. So you have something, maybe a tension pneumothorax that's squeezing your mediastinum, it's compressing your SVC, it's compressing your IVC. You don't have enough blood return to the heart. Stroke volume goes down. Or tamponade, stroke volume goes down because your ventricles are being smushed by a large pericardial effusion. Or PE, stroke volume is down because blood flow can't get through the pulmonary arteries. And so we have a compensatory increase in SVR. So if we are going to build an algorithmic approach to shock, then maybe our first step should be here. We have one outlier here, where cardiac output is increased and SVR is decreased. But we're trying to build a physical exam-based algorithm so that we can rapidly assess patients with shock, which is a medical emergency, so we can decide what to do about it. And not all our patients have a SWAN that's telling us their cardiac output and their SVR. So how on physical exam might you tell if someone's cardiac output is increased? Extremities, what about their extremities? Great, so if they're warm, think about vasodilation, decreased SVR, increased cardiac output. Cool extremities are more suggestive of increased SVR, or clamping down on blood vessels. I heard somebody say vital signs. Great, what vital signs? Heart rate, blood pressure. Heart rate, what should be happening to those things? You certainly can have tachycardia from increased cardiac increased cardiac output. Though, remember that several of these types of shock, the problem was decreased stroke volume. So you also have increased heart rate in types of shock where cardiac output itself is actually decreased because stroke volume is so low. So tachycardia is very common, should be a clue that a patient might have shock, but is unfortunately not specific to distributive shock. So we said warm extremities. The other one is strong or bounding pulses as opposed to weak, or a wide pulse pressure, a large difference between systolic and diastolic blood pressure, mostly because diastolic blood pressure is so low in distributive shock. So we're going to build an algorithm here our first step could be, is cardiac output increased? If yes, it's septic or distributed. But if no, we still have 3 options left. So take a couple of minutes amongst yourselves and talk about some physical exam findings that might be specific for 1 or 2 of our remaining 3 types of shock. And then we'll come back in like a minute or 2 and talk about some ideas. Share what your group came up with as physical exam findings that might be specific for 1 or 2 of these types of shock. Anybody from the middle table? What did you guys think?
Thinking about like crackles in the peripheral extremities and to differentiate cardiogenic versus hypoglycemic shock.
Great. Edema, crackles. Love it. We said edema might be present in obstructive, cardiogenic, but not hypovolemic. Crackles. What type of shock should have crackles? Cardiogenic. Great. I agree. There is a little bit of overlap with obstructive here. Maybe from tamponade, but not the other ones. What else?
Some of the groups said JVD,
Great. So JVD, what type of shock should have JVD?
cardiogenic.
Great.
And, possibly obstructive.
Cardiogenic and obstructive. Agree. But not hypovolemic, correct? Great. So you guys have already come up with it. So the next branch point in our algorithm is there JVD or are the neck veins flat? If yes, we have hypovolemic. And if no, we're still left with cardiogenic and obstructive. So exactly as you guys said, the next branch point is, are the lungs clear? There's a caveat to this. If yes, most likely obstructive. And if no, the lungs aren't clear, if there are crackles, cardiogenic. Should also say that I did not invent this algorithm. It comes from a textbook that's called Principles of Critical Care. And I think that this last step is where the algorithm is not perfect. So cardiogenic shock from left heart failure should certainly give you pulmonary edema, right? Your left ventricle is not squeezing well. Blood flow is backing up into your lungs. Get crackles on a lung exam for pulmonary edema, get hypoxemia. But you can also have cardiogenic shock from isolated right heart failure, right? Someone comes in with a large inferior MI, gets right heart failure, in which case you shouldn't really have pulmonary edema. The problem is outflow from the right ventricle as opposed to the left. And then similarly, the lungs should be clear in tension pneumo, right? Maybe you have absent breath sounds on one side, you shouldn't have crackles. They should be clear in massive PE. Blood flow can't get into the lungs, so you don't have an opportunity for edema to develop. But in tamponade, pulmonary edema is not one of the hallmarks of tamponade, but you can imagine that with impaired left ventricular filling from a large pericardial effusion, you might get some backflow of blood into the pulmonary circuit. Usually doesn't happen because blood flow to the right side of the heart is also impaired. So you're not getting that forward flow from the right, just as you're not getting it from the left. But you could, in theory, get pulmonary edema from cardiac tamponade. And notice that we've spelled shock, S-H-O-C. The last one is combos, which is creatively done with a K. That is meant to be there to remind you if your patient's not fitting in this algorithm, think about a mixed picture shock. Maybe someone is coming in with both cardiogenic and septic shock because they have heart failure and they got pyelonephritis and then they got 4 liters of fluid and now they're in decompensated heart failure and they have both. And I am not typically a huge mnemonic person, but when the algorithm for shock spells shock, I can remember that. And then there are a couple other add-ons at the end that somebody mentioned earlier, adrenal insufficiency. The textbook also puts anaphylaxis here, which I think you could also argue is a type of distributive shock. But we'll have some unique features, wheezes on pulmonary exam, maybe urticaria or GI symptoms. Weird electrolytes, such as calcium and thiamine. You have severe calcium deficiency. You don't have the calcium you need to constrict the smooth muscles in your vasculature, so you can get hypotension and shock from that, rare but possible. Same with thiamine. Thiamine is a cofactor for the Krebs cycle aerobic metabolism. If you have severe thiamine deficiency, you essentially can't do aerobic metabolism, you can get shock from that. And then the last one is we did it, which is therefore iatrogenic. You just push fentanyl, you just give someone Versed, you're giving a sedative or an analgesic medication that cause vasoplegia and cause shock. So now we have shock, S-H-O-C-K, and A, and we. Which I think is a helpful way to, in the setting of an emergency, when you have to make quick decisions, run through in your head, make sure you're not missing why this patient might be in shock. Questions about this? Okay, great. So now we will apply it to a few cases. So let's go back to your first page, that page you got about Mr. Jones, who just wasn't looking good. He's nauseous, he's sleepy. He's the guy that came in last night with pre-syncope, recurrent falls, some dark stools. Has worsening tachycardia, heart rate's 125, it was 105 earlier, blood pressure's 105 over 80, it was 115 over 85. Is he in shock? Do you need more information?
Is it just sleepiness or you also like has some alternative stuff?
Great, so more information. He is sleepy, but you go to see him because you're worried about his heart rate. And he's really drowsy. You can wake him up and he'll tell you his name and he'll tell you where he is. But anything else you ask him, he just says, I'm just so tired, and he falls asleep. Worried? Yes, great. So we talked about shock as a manifestation of inadequate organ perfusion. So on physical exam, you might see encephalopathy, drowsiness. What else are you going to look for on exam to tell you why this patient might have shock? Great, temperature of his extremities, they're cold. So we've at least ruled out septic distributed based on exam. What else do you want to know?
What's his physical exam like?
Lung exam, lungs are clear. JVP, you can't see it at all. So what do you think? Hypovolemic shock? From what, based on his story? GI bleed, great. So sometimes it's clear on the story, sometimes it's not, so this already can be helpful. This guy ended up with hemorrhagic shock from a duodenal ulcer that had eroded into an artery. He got activated with massive transfusion protocol, got scoped by GI, and he recovered. Next patient, you just got from Mr. Jones, you successfully resuscitated his hemorrhagic shock. You sit down at the computer, but then you get another page. And it's another patient's nurse. She says, hey, Miss Cowan's blood pressure is low. It's 75/42. Can you come see her? You ask for the rest of her vitals. The nurse says her temperature is 38.1, her heart rate is 124. It was 85 the last time I was in there. Blood pressure 75/42. She'd gotten some fluids when she came in because her blood pressure was low, and it had initially come up to like 115/75, but now it's back to 70s over 40s. Respiratory rate is 22, and SpO2 is 89% on room air. You look down at your paper, and Ms. Cowan came in last night for some fevers, chills, and some flank pain. Is Ms. Cowan in shock?
Yes.
Yes, why do you think so?
It sounds like she has a nice picture of septic shock.
Uh-huh.
And then you gave her some fluids because she was initially responsive. So perhaps like an picture.
Great, great thing to think about. What, any other thoughts?
It's like in general, hypotension, refractory to fluids.
Great. So hypotensive, refractory to fluids. It sounds like maybe she came in with an infection, right? Fevers, chills, flank pain. So what are you going to look for on exam? Does she have warm extremities? She does. She's flushed. Her extremities are pretty warm.
Mucus membrane.
Mucous membranes look dry. Warm extremities in this story. Do you think you need more information, or do you think you know where she's in shock? Yeah.
Oh, I wasn't.
Okay.
How are her lungs?
Her lungs are clear.
Seems like septic shock.
Septic shock, great. So I love that you thought about cardiogenic shock getting worse after fluid resuscitation, which is possible. I'll tell you, she has a normal ejection fraction, she's never had heart problems to her knowledge. Why might a patient who came in with sepsis, who got fluids and who got antibiotics get worse? Wrong antibiotics, great, that's possible. Maybe she's never been to the hospital before. She has an E. coli UTI leading to pyelo, and you gave her ceftriaxone and she's better. Or maybe she's been here 7 times in the last 2 years and she's had MDRO, Pseudomonas, and we gave her ceftriaxone when we should have given her Ameripen. Great, so think about antibiotic choice. What else?
A new acquired hospital or hospital-acquired infection.
Certainly could have a new hospital-acquired infection, something we don't want to miss. She's been here for like 12 hours, so less likely, but certainly something to look for. How about source control? So she seems like she has pyelo. Maybe she has an obstructive stone that's causing her to have urinary stasis and lack of source control from that. Maybe she got a perinephric abscess. So great. Sepsis refractory to fluids, think about antibiotic selection and source control. Awesome. So that is exactly what she had. She had pyelonephritis. She had an obstructing stone. She got a urologic procedure to relieve the obstruction, and she improved. So you just got done taking care of Miss Cowan, but now you got another page. And it's another nurse on the other end of the phone, and he says, hi, are you taking care of Mr. Flores? His urine output decreased. It's only been about 5 cc's in the last 2 hours. You look on your paper, you see last night, Mr. Flores is another new admission. He came in for shortness of breath and some leg swelling. They give him 40 of IL-6. You ask for his vitals. His nurse tells you his temperature is 35.6. His heart rate is 105. Blood pressure is 95/60. Respiratory rate is 28. And his O2 set is 91% and 6 liters. Is he in shock? How do you know? Why do you think yes?
I mean, the decreased urine output tells us that his kidneys aren't sticking up blood
Uh-huh.
below 36 on tap. And I feel like anytime you see a lower BP with that sort of rise in heart rate, you start to think, okay, this is like where they live. They're like asking for more.
Great, I completely agree. So thinking about when you see hypotension, do they also have tachycardia? If yes, where this is a change and they're trying to compensate, you have somebody who's hypotensive with a normal heart rate. Are they chronically hypotensive for some reason, or why do they not be compensating? Are they beta blocked? Awesome. Thinking about some hypothermia, and then also urine output as a marker of renal perfusion. So we're worried this guy's not perfusing his kidneys. What else are you going to look for on his physical exam? You already know why he's in shock. Why do you think maybe what's going to tell you about an exam? How about his extremities? I'll tell you they're clammy. What's next? JVD, great. It's to the angle of his mandible. You can very clearly see it.
Yeah.
And his lungs, bibasilar crackles. Why do you think he's in shock? Cardiogenic shock, great. This guy had inferior Q waves, infralateral Q waves on an EKG, likely had a missed MI a few days ago, came in with decompensated heart failure. Great. And now you get one more page. Another patient's nurse says, hi, I wanted to let you know that Mrs. White's blood pressure dropped. It's 86/54. You look down, Mrs. White is 85, and she came in last night after a fall. Had a hip fracture. They were worried about her medical risk for surgery, so hasn't gone to the OR yet. Temperature's 35.9, heart rate is 128, blood pressure is 86/54, respiratory rate is 30, and O2 sat is 92% on 4 liters. Is she in shock? Why? How are you going to know? I saw some knots. Check her pelvis. Great. What are you looking for in her pelvis? Bleeding. Great. So you don't see any, you see some ecchymosis around the site of where she has this fracture. You don't see any obvious hematoma, bleeding. Haven't sent her for a CAT scan yet because people are worried maybe she's too unstable. But I love thinking about bleeding. What else might you think about? She is short of breath. She is working harder to breathe. Her respiratory rate is 30. She got here, it was like 20. What else are you going to look for on exam? Her lungs are clear. No wheezes, no crackles.
If she has any other skin changes.
Yeah, what kind of skin changes?
Like in cat embolism, you can check up with like purpura. And, like,
Great. Yeah, so you can get that like purpuric petechial rash. She doesn't have that. That's a great thought. Anything else?
How are neck veins?
Great, I love that you asked that. They are full. She has JVD. Cool. Her neck veins are full and her lungs are clear. Why might she have obstructive shock? PE, great. That's exactly what happened. She had a hip fracture at home, developed a DVT. Was put on DVT prophylaxis. We didn't know she had a DVT, so she wasn't on therapeutic anticoagulation. Had an embolized through her lungs. Had a massive PE. Great. So you guys did an awesome job. We defined shock. We said shock is inadequate organ perfusion, inadequate blood supply or oxygen delivery to meet the demands of the body. That often manifests as hypotension or encephalopathy or decreased urine output, maybe on labs and AKI and elevated lactate. We listed 4 main categories of shock: distributive, hypovolemic, cardiogenic, and obstructive. We built this physical exam-based algorithmic approach to a patient with shock and applied this to cases. Be reminded that the algorithm is a little bit imperfect down here, but it is a nice way, I think, to rapidly think through in your head when a patient is unstable, why they might be unstable. And you really only have to look for 3 things on exam. Are they warm or are they cold? Can you see JVD or can you not? Are their lungs clear or are they not? Maybe this will obviously tell you why a patient's in shock. Maybe the story itself makes it obvious. And when it's not obvious, I encourage you to think through this, at least with the shock, mnemonic, and awe, to think about more rare etiologies of shock, such as adrenal insufficiency, anaphylaxis, electrolyte abnormalities, or iatrogenic causes. Questions about this? Okay, great. Well, thank you guys.